In terms of the debate that we're going to have, Sundar and I, we could have probably had a better debate in the previous one about transplant versus no transplant. I would expect that our message here will not be that different in regard to maintenance therapy. So I'm supposed to take the yes position. You'll probably see me taking a maybe position by the end of the talk. So I certainly have worked with the usual suspects in myeloma, Takeda, Celgene, Onyx, and Amgen, and received speakers fees, consulting fees, done expert testimony, and have a wide variety of both basic and clinical research grants. So what are our goals for maintenance therapy? It's to reduce the risk of relapse, extend progression-free and overall survival. We want to maintain the response achieved following a new treatment with administration of drugs for a prolonged time period. You notice here I didn't just put first treatment, I put really any new treatment. The therapy itself must be convenient, safe, well-tolerated, and I don't mean short-term, but long-term. And that's where we're missing a lot of data, as you know. And it should not prevent the use of future therapies by the toxicity we've rendered on the patient from the current maintenance therapy, because obviously we don't have a cure yet, at least in the vast majority of patients. So some of the data with lenalidomide, with or without steroid maintenance therapy is shown here. There are 4 large studies shown here. I'll show you a meta-analysis a little later that we're just publishing. The most well-known study is the McCarthy study, 460 patients treated with intensive therapy, transplant that is, with 10 milligrams of lenalidomide. And certainly a dramatic difference in PFS and event-free survival, and in the single trial, as you see, in the red letters, the red numbers, a significant difference in overall survival. The French trial, which admittedly had limited time period for the maintenance, the Gay study and Dr. Palumbo's here, these 3 studies have all shown similar increases in PFS and EFS and have shown, however, no differences in overall survival in those 3. So we have a single study that's positive for overall survival and 3 that are not. So the first trial you're probably familiar with, of course, this 3-arm study published last year in the New England Journal of Medicine was Lendex, and that was with continuous treatment until progression or intolerability. The second arm was Lendex, but limited to 18 months. And then arm C was the classic regimen used throughout most of the world, and that was melphalan-prednisone and a thalidomide, quite a high dose, 200 milligrams, one that my patients don't often see until progression. And as you already saw in the previous talks, this has shown a nice difference in progression-free survival in favor of continuous RD and quite significant p-values. But again, once you stopped Revlimid, you saw no difference between MPD and RD18. Now again, the PFS was superior, certainly with continuous RD versus MPD and also RD18. But the planned interim, and I admit interim 4-year overall survival with continuous RD was 59%, and albeit that was superior to MPT, remembering that they stopped the T at 18 months, they didn't keep going. There's no difference between RD18 and RD continuous, 59 versus 56%, p-value 0.31, hazard ratio 0.90, and Kraus is 1. And the safety profile, there were similar AEs across all the arms. Neutropenia was actually higher in the chemo arm with MPT than RD, but the infection rate was higher with RD versus MPT, but guess what? They were on treatment longer. That may be the explanation for that. If you're longer time at risk, you may have more events. And then, of course, Dr. Palumbo published last year a 4-arm trial, phase 3, 273 patients. Induction was either Lendex, and then randomization to 4 arms, about 65 patients in an arm, with oral MPR for 6 cycles, no maintenance, MPR, and then R alone maintenance, double transplant without maintenance, or double transplant with Rev maintenance therapy. And as you see in this slide, although you had a better progression-free survival if you had 2 transplants followed by Rev, that was the best, and you did better as well with if you up front and then if you got MPR, continued R versus MPR. When you look at the 4 arms for overall survival, there's no difference in survival between any of them. Now, when you combine the arms of the 2 that got the R maintenance, both in the transplant and the non-transplant setting, although there's a dramatic difference in progression-free survival, there is no difference in overall survival between the arms. We got a paper just accepted in the last few days. It's going to be in the Journal of National Cancer Institute, part of a collaboration, most of the work done by the MD Anderson group I'm part of, a meta-analysis of 7,730 patients from 18 phase 3 trials. And although progression-free survival is clearly improved in both the transplant and non-transplant patients who receive lenalidomide or I should say thalidomide maintenance therapy, and this includes whether you stratify for Len and Thal as well, there is no overall survival benefit. This, if you break it down into transplant, non-transplant, Len, Thal, you subset them and stratify, it doesn't matter. There's no overall survival advantage. And there certainly are more grade 3 and 4 adverse events, as you might guess, with the use of an IMiD. Thromboembolic events, in fact, I just got called a few minutes on a patient who had one of those who's on maintenance therapy with Rev and steroids. Peripheral neuropathy events higher, neutropenia, and more importantly, infection. So in this compilation of the data to date, PFS clearly benefited, but OS is not. So the role of lenalidomide maintenance therapy, fairly consistent results showing improvement in PFS. I think we can agree to that. However, inconsistent results showing improvement in OS. In fact, most studies do not show improvement with the exception of the McCarthy trial in the setting of transplant. The meta-analysis I just mentioned, over 7,700 patients, shows no overall survival advantage. Really importantly, there's no studies that show using lenalidomide for patients who have responded to a regimen that does not contain that agent does anything in terms of PFS or OS. So throwing lenalidomide into a patient responding to a proteasome inhibitor without an IMiD, I believe there's no support for doing that. What about the role of Bortezomib in maintenance therapy for myeloma? There's few randomized trials, and unfortunately, there's inadequate trial design to determine the impact of Bortezomib itself in the maintenance therapies. There's trials, I'll show you examples of all these, induction with Bortezomib, followed by maintenance Bortezomib in one arm, and the other arm has no Bortezomib in either induction or the maintenance arm. There's different induction regimens. There's maintenance regimens in which both arms contain Bortezomib with different additional agents. And on the other hand, there's studies in which both arms contain another drug, for example, thalidomide, but only one arm contains Velcade. It's very hard to separate this data out to tell you for sure that Bortezomib works as a maintenance drug. So specifically, Dr. Palumbo again here has done a lot of work on this. This is a 4-drug VMP thalidomide followed by Velcade thalidomide maintenance. And you'll notice the other arm has VMP, has no thalidomide, and has no maintenance down here. So one arm gets a different regimen up front, 4, and gets maintenance. The other arm gets a 3-drug regimen and no maintenance. Pretty hard to interpret results of what maintenance is doing. So efficacy data overall clearly shows superiority in terms of PFS, both 3-year and median, in favor of the 4-drug with VT maintenance versus the 3-drug VMP, as well as 3-year time to next treatment, both the 3-year and median time to next treatment, all of this superior with the 4-drug combination with Velcade thalidomide maintenance, but remembering there's only 3 drugs in the other arm, and there is no maintenance therapy. OS is also superior, as you see here, a p-value 0.01. So again, the 4 drugs with VT is superior to VMP. Following relapse, as you would guess, there's no difference in overall survival between the arms following relapse. Adverse events, not as different as you might suspect between the arms, more neutropenia, but again, patients are on longer, more DVT and PE here, some more infections. And if you look discontinuation rates, the big difference was in those over 75, more than doubled discontinuation of the 4-drug VT regimen versus VMP, as you see here. What about the impact of maintenance therapy itself? Well, a landmark analysis was completed after 9 cycles, showing a 52% reduction of risk of progression with the 4-drug regimen with the maintenance Velcade and thalidomide versus VMP, irrespective of response, shown in patients less than 75 but not greater. And a number of prognostic factors were looked at as well. AEs during maintenance therapy, remembering that's only on one arm that got the 4 drugs up front, pretty low numbers here of new events. So again, this is a landmark analysis and obviously is not really a randomized, we'll look at the data in a way that we can interpret it clearly. So what is the impact of maintenance therapy here? I don't know, because you have 4 drugs with VT versus 3 drugs without maintenance therapy. I don't think we have a clear-cut answer from this trial. There was a trial done from the PETHEMA group in which Bortezomib was evaluated as maintenance therapy in previously untreated myeloma. Endpoints, PFS, secondary response rate, OS, and safety, 386 patients, and there were a variety of induction regimens, what we care as maintenance. It was Bortezomib alone, standard dose and schedule, but only given 4 days every 3 months, not 3 weeks, with thalidomide 100 milligrams daily versus thalidomide alone. And then they added interferon, a drug we used to use and haven't used much, but I think it may be getting reinvented. You can ask me about that. This clearly shows that responses before the initiation of maintenance therapy are inferior to what you see following. So we bumped CRs from 53 to 74 here in this group with VT, from 49 to 63 in the thalidomide, and 53 to 69 in interferon. So all groups are throwing an up CR rate following maintenance initiation, but we really cannot tell you, unfortunately, there's any overall survival difference between the arms. So the addition of Bortezomib to thalidomide results, again, in a longer PFS versus the other 2 arms, but there is no difference in overall survival between the arms. The Bortezomib maintenance conferred a significant PFS advantage in patients with low-risk disease, interestingly, but not among those with high risk. There was no difference in that subgroup. So there has also been a trial of VMP versus VTP, and in this trial, again, we have differences in the induction. We have 4 arms here in maintenance, either Velcade, Thal, Velcade, Prednisone. So Velcade is in everybody in maintenance, in one case with thalidomide and the other case with prednisone. And again, following maintenance therapy, we're bumping CR rates in VMP from 20 to 46, VTP following VP, I should say VP up to 39. So we are bumping CR rates here versus what we're seeing during induction. Again, we're upping the CR rates. Unfortunately, although we do that, there's no significant difference between PFS and OS between the VMP and VTP arms, and also following maintenance, there's no difference. So whether you use thalidomide or prednisone with Velcade, there is no difference here during the maintenance phase. So the type of maintenance therapy also did not impact outcome whether you had high risk or standard risk patients here in subgroups. So what about Bortezomib as a maintenance therapy for patients during Salvage? Well, one study recently looked at in cancer, Bortezomib and Dex here, and every other week, and this is kind of what we do, 49 patients. Responses improved in 7, 4 got to CR, 3 to VGPR. Time to progression, median 16 months. 1-year PFS 61%, OS 79%. Well tolerated, but 3 patients did develop grade 2 peripheral neuropathy on the long-term Bortezomib out of the 49, but single arm, obviously hard to interpret. But we do have oral agents coming along. You've heard about Exazimid. You've already seen the results of this from Dr. Palumbo's talk. Phase 1-2 study from Rachaji Kumar, fixed dose at 4 milligrams given maintenance therapy with Bortezomib alone after the 12 cycles of induction. We did see very high CR or OR rates and good CR rates, and during the maintenance phase, 20% of those patients who got there improved their depth of response. Proteasome, we are certainly working on that with a lot of you out there. A work in progress. Certainly, we've got to get a better GI-tolerated drug. So, summarizing, lenalidomide maintenance therapy with or without steroids is well tolerated, improves PFS, but not OS among myeloma patients. Also, this is true with thalidomide, and this is true both in the transplant and non-transplant settings. Again, there's no data suggesting that this drug is active when used with when other drugs have been used upfront without an IMiD. And Bortezomib responding patients tolerate its long-term use as maintenance therapy. As I've shown you, the responses deepen during maintenance therapy, but its efficacy in terms of PFS or OS has not been clearly demonstrated due to trial design limitations I've shown you. Oral PIs are in clinical development. Their convenience makes them more ideal as maintenance drugs. And of course, there's ongoing trials now with Bortezomib. And in the last slide, what do I actually do? I give maintenance therapy both in the frontline and salvage settings. I discontinue the chemotherapy agents. If a patient is on an IMiD, PI, or steroid-containing regimen, I continue those drugs until disease progression or intolerability. I may take the doses down, for example, the steroids. But I don't start drugs the patient was not on as part of that treatment regimen. I don't add in a lenalidomide if the patient was on a regimen without it before they started maintenance. I don't change the dose or schedule the IMiD. The PIs we administer every other week, the Bortezomib at 1.3 and the carfilzomib at 27, 2 consecutive days every other week, but that might change, hint, hint, some of you know. Steroids, I continue the same dose intensity per month. We try to establish 160 milligrams of dex monthly. We give that as methylprednisolone 40 milligrams every other day, or dex every other week when they're coming in for their PI, along with methylprednisolone at 20 every other day. And I thank you. Thank you very much.